Okay, so we are going to get started. Our first speaker for today is Dr. Nadine Shehata, who is the Medical Director for Transfusion Medicine at Sinai. She is also the obstetrical hematologist for the high-risk program at Mount Sinai. So an excellent national, international expert on pregnancy and transfusion. So welcome, Nadine. I'm going to stop sharing my slide and turn it over to you.
Good morning, everyone. I'll be discussing alloimmunization secondary to pregnancy and transfusion in women of childbearing age. I have one main objective for the next 30 to 40 minutes is to have you really appreciate the effect of red cell immunization in women of childbearing age. Then I'm going to categorize the presentation into two, how to prevent exposure from paternal antigens and therefore prevent alloimmunization from paternal antigens by the use of Rh immunoglobulin. And two, we're going to focus on how to prevent immunization from red cell transfusion, and in so doing, appreciate the changes in hemoglobin levels and transfusion criteria for women of childbearing age, as well as alternatives to transfusion. So I'll start the presentation with a case scenario. This is a 28-year-old G1 at 22 weeks gestation. She's D negative and has vaginal spotting. You, assuming the partner is D positive, advise for Rh immunoglobulin, advise for Rh immunoglobulin and testing for fetal maternal hemorrhage, or test for fetal maternal hemorrhage only. And the answer here is 2. So I'm just going to start with a few background slides. First of all, alloimmunization is essentially development of an alloantibody and occurs following the exposure of a foreign antigen. And for a woman of childbearing age, that exposure can be due to paternal antigens, by fetal maternal hemorrhage during pregnancy, or obviously exposure by red blood cells. Following exposure to antigens, either an IgM or IgG antibody can develop. An IgG antibody, however, is the only type of antibody that can traverse the placenta. IgM antibodies do not traverse the placenta. And IgG antibodies, if they traverse, they can bind to fetal antigens in the red cells, resulting in uptake of those red cells and destruction of those red cells, resulting in hemolytic disease of the fetus and newborn. The ability to develop an alloantibody depends on the following characteristics. As not all women who are exposed will become alloimmunized, and as you can see on the bottom there, approximately 16% of women become alloimmunized. So the development of an alloantibody depends on the immunogenicity and embryonic development of the red cell antigen, the volume of the red cell antigen exposure, and the immune responsiveness of the individual. I'll start first with the immunogenicity and embryonic development of the red cell antigen. So certain antigens tend to be more potent immunogens, so such as polypeptide antigens, and they tend to give rise to IgG alloantibodies. So for instance, antigens of the Rh class versus carbohydrate antigens will give rise to IgG antibodies. Carbohydrate antigens will give rise to IgM antibodies. And examples of that include ABO, P, Lewis, and I. Obviously, the development of an alloantibody following paternal exposure really depends on when that antigen develops during pregnancy. So for instance, for the D antigen appears very early on, as early as about 38 days gestation, whereas AB antigens tend to develop postnatally. So the ability to develop an alloantibody also depends on the volume of red cell antigen exposure. And during pregnancy, transplacental hemorrhage, albeit not a very large volume, but does occur quite commonly, exposing the mother to paternal antigens. Essentially, in the first trimester, almost 56% or almost 60% of women will be exposed to fetal antigens, albeit the volume is not that high, 0.07 mils. And in the second trimester, more women will tend to get exposed, again, with a little bit of higher volume. Similarly, in the third trimester, the volume increases, and the proportion of women that have that transplacental exposure will also increase. And this is the rationale of really using Rh immunoglobulin in the third trimester. That exposure proportion and the exposure amount is also going to depend on whether there are invasive procedures that are undertaken during pregnancies, such as CVS or amniocentesis, or if trauma occurs, and obviously at the time of delivery. Now, with transfusion, there's a higher volume, obviously, that is being given to the woman of childbearing age. And as an example of what proportion develop alloantibodies, I've indicated there that about 15% will develop an alloantibody after about 1 mil of RBC exposure, but that's not really the volume of the whole red cell unit. After about 250 or 290 mils of transfusion, which is the whole red cell unit, because of the potency of D as an immunogen, about 70 to 90% will develop an alloimmune response. That's the first exposure. After a second exposure, the volume to get that antibody response again can be as little as 0.03 mils of red cells. So for instance, if someone has been exposed previously in the first trimester, if the first trimester is 0.07 mils, that antibody response can appear in the first trimester. The ability to develop an alloantibody also depends on the immune responsiveness of the individual. And so that is going to be dependent on the characteristics of the antibody and whether there is an incompatibility that can result in destruction of the antibody or uptake of the antibody. So I've categorized characteristics of the antibody into sort of 3 large categories: the ability to present red cells, so dependent on HLA genotype, the ability to lyse, and the ability to suppress erythropoiesis. And as an example here, the K, an alloantibody to the K antigen can cause erythropoiesis suppression, and so therefore makes the individual more at risk of developing severe hemolytic disease of the fetus and newborn. When it comes to having an alternate antigen available to take up that antibody, it is known that patients with ABO incompatibility tend to have less severe disease because of the binding of the antibody to the AB antigens. So because of all these factors, there is a range of risk when it comes to hemolytic disease of the fetus and newborn. Either some patients will not develop any destruction of red cells, and that's what you can see on the right-hand side there, or on the left-hand side there, and on the right-hand side is really severe disease, which is fetal hydrops. Less severe disease than fetal hydrops is going to be hemolytic disease of the fetus requiring intrauterine transfusion, and some women will just have hemolytic disease of the fetus and newborn with hyperbilirubinemia and anemia. If we look at the antigens that are associated with more severe risk of disease, the D, K, and little c antigen tend to be associated with more severe disease overall. E antigen tends to occur commonly, but is not associated with severe disease in comparison to D, K, and little c, and Duffy tends to have a variability with regards to severity of disease overall. And severe disease here is defined as requiring intrauterine transfusion or neonatal exchange transfusion. So if the intent is to prevent alloimmunization from exposure, and the 2 exposures are paternal exposure from pregnancy and transfusion exposure, from a paternal perspective, the only means of preventing exposure to paternal antigens is Rh immunoglobulin for exposure to the D antigen. There aren't any other interventions that prevent paternal exposure to the other antigens. From transfusion, it's really transfusion avoidance, or if transfusion is actually required, is to give antigen negative transfusion, so D negative for those that are D negative, and K negative for those that are K negative to prevent alloimmunization. I'll talk next about Rh immunoglobulin. So the question prior to discussing Rh immunoglobulin is, if a patient is exposed, when should Rh immunoglobulin be administered? Within 24 hours, within 72 hours, within 72 hours, but up to 10 days. So the answer here is C. Obviously, Rh immunoglobulin should be given as quickly as possible to prevent alloimmunization, but can be given up to 10 days, and some would suggest up to 28 days if the patient is not alloimmunized. So Rh immunoglobulin, briefly, it is a plasma-derived IgG product. It is made from multiple donors, but it is protective for exposure of the D antigen. The risk of contracting viruses is reduced by the manufacturing process, which includes solvent detergent treatment as well as nanofiltration. I mean, it's thought that Rh immunoglobulin works by either binding the D antigen before it's seen by the reticular endothelial system and taking up those cells, or somehow by altering the process of D antigen, the processing of D antigen, so that T and B cell activation do not occur. So if prophylactic if prophylactic Rh immunoglobulin is administered, that risk of alloimmunization that I indicated on the first slide of 16% is reduced to about 0.2 to 1%. It is not zero, and it's probably not zero just because there are various exposures to women, and often Rh immunoglobulin is not administered. Generally, when there is exposure, approximately 300 micrograms will suppress the response of up to 15 mils of red cells. So that, as I mentioned in previous slides, the volume, the proportion that are exposed to transplacental hemorrhage and the volume of transplacental hemorrhage increases by the third trimester. The 300 micrograms is given at approximately 26 to 28 weeks to prevent that exposure to the D antigen from a fetus that potentially has D. And within 72 hours of delivery, if it's shown that the fetus is D positive or is D unknown. But if there are additional exposures, which are potential sensitizing events, so besides the prophylactic use of Rh immunoglobulin, really Rh immunoglobulin should be given. And the dose is about 120 to 300 micrograms prior to 12 weeks, and that dose is based on the fact that the blood volume is much smaller than it is obviously later on in gestations. Between 12 to 20 weeks, approximately 300 micrograms. And then more than 20 weeks, a standard of 300 micrograms is given. But in addition to that, that testing is done to determine the presence and the volume of fetal maternal hemorrhage overall. And I've indicated the test there, Rosette, the Beck-Kleyer-Hauer test, or flow cytometry, which is offered at certain institutions to determine the volume of the bleed. Postpartum, also about 120 to 300 micrograms is given if the neonate is D positive or D unknown. And again, BK or flow cytometry testing is done to determine if additional Rh immunoglobulin is required. So I just want to give you a little bit of a background about the type of testing that's done to determine the volume of fetal maternal hemorrhage, the presence and the volume of fetal maternal hemorrhage, and first discuss the Beck-Kleyer-Hauer acid elution test. So what this test does is it detects hemoglobin F. Hemoglobin F tends to be the predominant hemoglobin of the fetus, and so tends to not be natured by acid. So it's acid resistant, and so that fetal cells will appear as dark pink or red. And if you notice on the right upper part of the screen, a positive test is showing there. There are 3 cells in the field that are positive. This is fetal hemoglobin. The adult hemoglobin, which is predominantly hemoglobin A with approximately 1% or less of hemoglobin F, actually is denatured by acid. And so essentially the cells of the adult appear as ghost cells. And so that is on the lower part of the screen. And how this test quantitates the amount of bleed is essentially the cells that appear as red or pink are counted on a background of number of cells and multiplied by the volume or the total blood volume. The BK test, though, detects hemoglobin F, and there are certain patient populations that have a high proportion of hemoglobin F, such as patients with sickle cell disease or thalassemia. And even in pregnancy, the amount of hemoglobin F actually increases. That some women will have as high as approximately 7% of hemoglobin F by 32 weeks overall. So that a better test with regards to detecting patients who have a maternal fetal hemorrhage in those scenarios is going to be flow cytometry. Flow cytometry is also better at estimating more accurately the blood, the amount of bleed overall. And as you can see in the graph on the right-hand side is really the differentiation of adult cells, adult F cells, and fetal cells. So therefore it's a more accurate test, albeit it's not available widely. So we discussed alloimmunization from paternal exposure and that prevention. The next, we'll discuss alloimmunization from red cell transfusion. So what I'd like to do in the next 10 minutes or so is to have you appreciate the changes in hemoglobin levels during pregnancy, the indications and alternatives for transfusion to try to prevent this exposure for alloimmunization. So again, a case scenario, this is a 25-year-old female. She's G1P0. She's 27 weeks gestation with vaginal spotting. Her hemoglobin is 70. Would you want to transfuse red cells? And obviously 2 options, yes or no, and I'll let you consider this. There's no right answer for this one. It's more so from the perspective of when you're considering whether or not to transfuse are the benefits really worth the risk? So for instance, is the mother compromised by the anemia? Is the fetus compromised by maternal anemia? Or are there alternatives to prevent both alloimmunization and alternatives to reduce symptoms from the mom and symptoms for the mother and potentially any symptoms for the fetus? So first, I'll discuss the physiological changes during pregnancy. And as you know, the total blood volume does increase with pregnancy, obviously, as there's increase in maternal blood volume. And that blood volume increases approximately 1.5 liters overall. So plasma volume increases, as does red cell mass increase, but the plasma volume increases more so than the red cell mass. So essentially, there looks to be a hemodilutional anemia that occurs during pregnancy. And what you can see on the graph on the right there is the weeks of gestation, and on the left is the percent changes. The blue is the blood volume, the yellow is the plasma volume, and the red is red cell volume. So maximum increase by approximately the 3rd trimester, but normalization does not occur until 6 weeks postpartum. And so when it comes to defining anemia in pregnancy, anemia in the 1st trimester is less than 110 grams per liter because of this increased volume relative to red cell mass, whereas in a non-pregnant female will be less than 120. In the 2nd and 3rd trimester, anemia is defined as a hemoglobin less than 105 grams per liter, although other sources such as the WHO would suggest that anemia is defined less than 110 grams per liter in the 3rd trimester. In the postpartum setting, and similar to what I showed on the graph in the previous slide, that blood volume is maximal at that point in time, that immediately in the postpartum period, the definition of anemia is going to be less than 100 grams per liter overall. So there aren't any randomized controlled trials in the antepartum setting that try to determine what the optimal hemoglobin concentration is for pregnant mothers, but there's been one that has been conducted in the postpartum setting. And this took approximately 500 patients, predominantly who had a vaginal delivery, and randomized them if they were anemic, as defined by hemoglobin of about 48 to 80 grams per liter, to 1 unit of red cells or no transfusion. Now, these patients were hemodynamically stable, obviously not actively bleeding and requiring transfusion. And what they showed that women at this point could actually tolerate approximately 50% drop in their hemoglobin concentration without too many symptoms. And so what you can see on the graph on the right there is weeks postpartum, and on the vertical axis is physical fatigue. Red blood cell transfusion is in red, non-intervention in blue, and a reference vaginal delivery, so it was a case series that they had reported previously, in black. And so at approximately 7 days, women, obviously at lower hemoglobins, did complain more so of fatigue, but by the time they were 42 days postpartum, those symptoms were relatively the same. Now, this is not to say that a hemoglobin of 50 should not be treated overall. It may not be treated by transfusion, but since the likelihood is that these patients bled, then they should be treated with iron. So iron deficiency obviously can occur in the postpartum setting with postpartum bleeding, and it tends to be the most common cause of anemia in pregnancy, approximately 20%, with some sources citing up to 30% overall. Obviously, there are increased iron demands during pregnancy because of fetus that is developing, and generally a prenatal vitamin has approximately 27 to 30 milligrams of elemental iron. And if taken routinely every day, it can then replenish the iron requirements, which are approximately 1.2 grams that are required during pregnancy. There is a risk, though, of iron deficiency, obviously, if women can't tolerate iron, if they have hyperemesis or nausea and vomiting where they can't tolerate oral iron in the first trimester. And there tends to be a higher frequency of iron deficiency if pregnancies have been closer together, if there's been a previous postpartum hemorrhage, if for women who have low socioeconomic status, and those that are multiparous overall. So current recommendations are that at approximately 12 weeks gestation, women should have a CBC to screen to determine if they're anemic. However, some would suggest that if there are additional risk factors, such as what I've indicated there, then a ferritin and iron saturation or iron indices be done at 12 weeks to exclude that iron deficiency. So that the criteria for defining iron deficiency are going to be a ferritin less than 30 micrograms or fasting iron saturation less than 15 to 20%. I've asterisked other parameters that can be accessed at specific labs, such as a low reticulocyte hemoglobin, low hepcidin, and an increased soluble transferrin receptor that are not widely available, but if available, can also indicate iron deficiency. This slide is more for information. The most common iron supplements that are used are the iron salts, those being ferrous fumarate, ferrous gluconate, and ferrous sulfate. The prenatal vitamin has ferrous fumarate predominantly, although some have ferrous gluconate. Essentially, the highest amount of iron is going to be in ferrous fumarate and lowest amount in ferrous gluconate. There are other iron compounds that are used, but tend to have lower absorption of iron overall. If it is needed in that the iron needs to be replenished rapidly, then intravenous iron can be used in pregnancy. Ferrous iron sucrose tends to be the most common iron intravenous preparation used in comparison to others, and has been used widely in randomized controlled trials. The dose essentially is calculated by the formula I put at the bottom of that slide, which is the Genzoni formula. So essentially, as I mentioned, the response to IV iron is faster than oral iron. What is to be expected that if oral iron is given, that you would expect a hemoglobin rise by approximately 1 gram per liter per day after starting. The hemoglobin would normalize in about 6 to 8 weeks. If there's no bleeding or anything else that can interfere with iron absorption. However, even if the hemoglobin normalizes, it's important to continue oral iron supplements, and so that iron stores are to be replenished if daily iron is taken by approximately 3 to 6 months. If IV iron is given, what is expected is that it will raise that hemoglobin concentration and iron parameters twice as fast. Generally, IV iron is well tolerated in pregnancies. These are young, healthy women, and no hypersensitivity reactions have been reported in a large number of patients in a recent systematic review. So when should IV iron be used? When there's moderate to severe anemia, when there's no response to oral iron, when there are side effects which can occur commonly in pregnancy, and when there's limited time to delivery. What I've shown you there, the table on the right, was a very large randomized controlled trial that compared oral iron to IV iron sucrose. And what I've highlighted is the change from baseline to delivery, just to, again, illustrate that IV iron will increase iron parameters faster, and that the proportion with anemia then will decrease faster with IV iron in comparison to oral iron. And so that when we look at complications because of iron deficiency from a maternal perspective, it has been shown that giving IV iron will increase the hemoglobin, and by increasing the hemoglobin overall, it reduces the risk then of someone receiving a transfusion, because most people will follow a hemoglobin criteria to transfuse patients. Giving IV iron as well will reduce maternal symptoms such as fatigue a little bit faster than oral iron will overall. With regards to fetal adverse outcomes secondary to iron deficiency, there's a lot of conflicting evidence about fetal outcomes. The randomized controlled trial that I described on the previous slide didn't show any association with fetal outcomes, but there have been other studies that suggest that perhaps cognition is affected, and a recent randomized controlled trial suggested such cognitive defects such as such cognitive problems such as attention deficit disorder could occur more frequently if, for instance, in the first trimester, iron deficiency anemia is not treated. Alternatives besides IV iron for anemia that is used, for instance, in patient blood management for other patient populations, such as the erythropoiesis stimulating agents, are not routinely used in pregnancy. Current guidelines would suggest that there is an indication for use in patients who have renal failure, for instance, or patients that don't have any other alternatives from the perspective of having multiple antibodies, or for whatever reason are that they cannot be cross-matched. Erythropoiesis stimulating agents tend to be large molecules. They don't traverse the placenta, but larger studies in terms of adverse events have not been conducted for for routine use during pregnancy overall. So then if iron deficiency is treated, and if there are no alternatives that are available, when should a patient be transfused in the antepartum setting, as there have been no randomized controlled trials comparing hemoglobin criteria? The Royal College of Obstetrics and Gynecology would suggest that there are no firm criteria for initiating red cell transfusion, and the decision to provide blood transfusion should be made on clinical and hematological grounds. In the absence of hemorrhage or hemodynamic instability, red cell transfusion is almost always required when the hemoglobin is less than 60 and is rarely required when the hemoglobin is greater than 100. The American College of Obstetrics and Gynecology would suggest that maternal transfusion should be considered for fetal indications, and there are some studies that suggest that potentially there's fetal compromise at hemoglobin concentrations less than 60, and so that if the hemoglobin is coming close to there, at least give IV iron to ensure that the hemoglobin concentration doesn't fall lower than that, so that there isn't fetal compromise. And from an obstetric perspective, there are Doppler ultrasounds of the MCA that can determine whether or not there's potential for fetal compromise. Okay, so back to that case scenario. She was 25 years old. She was 27 weeks gestation. She had vaginal spotting and her hemoglobin was 70. She was transfused 1 unit of red cells, and postpartum she has an antibody screen, and unfortunately she's developed an allo-anti-C. She now wants another pregnancy. So if an allo-antibody is detected, the first step is really to determine whether or not that came from a previous transfusion, or if it's a paternal antigen. So it's determining whether the partner has the antigen, and then if the partner is heterozygote or homozygote. If that cannot be done, and if the fetus is potentially affected, the next step is to determine serial antibody titers, and that is immediately when the patient is pregnant. And serial antibody titers essentially is a method to determine the strength of the antibody, and I've given you an example or a diagram of that on the right. Essentially what an antibody titer is, it's the greatest dilution with a positive agglutination reaction. Alternatively, for Rh antigens, specifically CD and E, cell-free fetal DNA can be done at 18 weeks gestation onward to determine whether or not the fetus has that specific antigen, and it's a non-invasive test and is routinely done now in pregnancy, as opposed to using antibody titrations and not knowing what the fetal antigen status is overall. But for whatever reason, if cell-free fetal DNA is not done or is not available, then really it's serial antibody titers throughout pregnancy to determine risk of hemolytic disease of the fetus and newborn. The allo-antibody titer for DC and E in a first-time pregnancy should be done every 4 weeks in the first and second trimester, but the frequency is increased to every 2 weeks if there's an increase in titer or in the third trimester. Referral to high-risk center is then done if in a first pregnancy when the allo-antibody titer is greater than 1 in 16 to 1 in 32, and this is considered a critical titer. And the term critical titer essentially refers to that there's potentially an increased risk of hemolytic disease of the fetus and newborn. It doesn't equate with actually the fetus having hemolytic disease of the fetus and newborn. However, for the K antigen, overall, any titer should be referred because, as I mentioned in earlier slides, alloantibodies to K can cause suppression of fetal erythropoiesis. So the titer concentration may or may not be associated with risk overall. For any pregnancy that has been alloimmunized and has had a fetus that's affected, either by hemolytic disease of the fetus or hemolytic disease of the newborn, where the newborn is hyperbilirubinemic and or anemic, for a subsequent pregnancy, all those patients should be referred on and be monitored early in pregnancy, as the risk of getting hemolytic disease of the fetus and newborn is higher earlier on in gestation. I'll stop there and summarize. The overall objective was really to appreciate the effect of red cell immunization in women of childbearing age, as alloimmunization leads to a risk of hemolytic disease of the fetus and newborn. The means that we have of reducing risk of alloimmunization from paternal exposure is to give Rh immunoglobulin for routinely during pregnancy, as well as for any additional risk, and it should be given as soon as possible when that individual has the risk. From the perspective of red cell transfusion, I just wanted you to be aware that hemoglobin concentrations that define anemia are a little bit less than what they are outside of pregnancy. Iron deficiency tends to be common, and so transfusion is really reserved for those patients who tend to be symptomatic and don't have alternatives, or potentially if the fetus can be compromised by the anemia, and in so doing, a transfusion is administered. And if the transfusion is administered, D negative is given to moms who are D negative, and K negative is given to moms who are K negative to reduce the risk of alloimmunization overall. I'll stop there.
So just opening it up to any questions that people have received, and Casey is starting to put those into the chat box. So the first question is whether the Betke-Kleihauer test is valid in adult patients with hemoglobinopathies.
Yeah, so the BK test can't be used in adult patients with hemoglobinopathies. It's not accurate. So it is better to use flow cytometry in that patient population.
And kind of on the same line, so if patients had sickle cell disease in terms of the moms, the recommendation then would also be to try to do the hemoglobin F flow cytometry. Okay, next question. If someone's given Venofer during an inpatient admission, should they also be discharged on oral iron for 3 to 6 months?
Yeah, so it's important to estimate the amount of iron requirements and then determine how much iron to give. So if the iron requirements can be fulfilled by the Venofer 300 milligrams, then Venofer 300 milligrams is all that's necessary. But if the patient is profoundly iron deficient based on that Ganzoni formula, then they certainly should be discharged home on oral iron. For women who are breastfeeding, they should also be taking a prenatal vitamin, because similarly to pregnancy, breastfeeding is associated with increased iron requirements.
Great. The next question is whether most blood banks select antigen negative blood for all childbearing women, or do you have to specifically ask for it as a clinician?
So D negative is standard. K negative, at least in the academic centers in Toronto, is provided for women of childbearing age. In other centers, it may not be automatic, and so you might have to ask for it.
And just in terms of D negative, that would only be for D negative, like we would match the ABO RH type. So D negative would just be for the D negative patients. If they're D positive, then they wouldn't necessarily get D negative in those cases. Next question, can you give multiple doses of Venofer? And if yes, what is the appropriate time interval between doses?
You can give multiple doses of Venofer, but Venofer can only be given on alternate days. And essentially, you can give as much Venofer as required to replenish iron stores based on that Ganzoni formula.
Okay, great. The next question is always a hard one that we struggle with. So if you have a mother who, an Rh-neg mom who is having repeated antepartum hemorrhage in the 3rd trimester, how frequent should you repeat the RIG dosing?
Yeah, and that becomes a very difficult question, and sort of, I'm going to say the simple general answer is err on the side of caution. But practically speaking is that you're doing fetal maternal hemorrhage to determine the amount that you should be giving. fetal
it's always
hemorrhage testing, so like BK testing or flow cytometry.
Yeah, we always struggle with this question too, where patients have sort of continuous vaginal bleeding, and we always find that that's really challenging. So we would, repeat it every 3 days, but if it increases, then we repeat it earlier and figure out what to do in terms of the
Yeah,
rate.
and that's an important point. If it increases, so if there's any increase, it's important to repeat.
Another great question is monoferric ferric maltose. Is that harmful for pregnant patients, and do we have any data supporting its use?
So there are a lot of centers that use monoferric. The difficulty is the monoferric monogram actually says do not use in pregnancy. Practically speaking, it's risk versus benefit. We give Venofer in pregnancy because the monograph doesn't say not to give it in pregnancy. It's just that there are no long-term studies. So when there's a situation where that's the only option that you would have, it's really discussing risks and benefits with the patient.
Okay, great. Next question. Can we give higher doses of RIG-D or D immunoglobulin greater than 300 micrograms at a time, especially if the percent of fetal hemoglobin is very high?
So if the fetal maternal hemorrhage is high and higher than, what a 300 dose of 300 microgram dose of Rh immunoglobulin cover, then certainly you're giving that additional dose to ensure that the entire fetal maternal hemorrhage is covered. Perhaps I should clarify that on the slide. The 300 microgram dose is that first dose. Then you're doing fetal maternal hemorrhage to see if you need to give any additional doses.
Yeah, and that's a question that comes up all the time. People are like, okay, Cly-Howard-Becky is negative. That just means you don't have to give any extra, and we're not able to pick up, but you do need to give that first dose and determine if you need more with the Cly-Howard-Becky or fetal maternal hemorrhage test, whichever you're using. Just a reminder, again, Nadine, if you can remind which are the antibodies that carry the most risk of HDFN?
Sure. So D, K, and little c tend to be associated with the most severe hemolytic disease of the fetus and newborn.
And what are the most common adverse events related to anti-D administration?
Yeah, extremely rare to get any side effects to RIG administration overall. There hasn't been a case of viral transmission for years to Rh immunoglobulin. So it's essentially pain from the IM injection, a little bit of bleeding from the IM injection, and rarely an allergic reaction.
And I think we'll just take the sort of two questions. Can you comment on first trimester IV iron risk?
Yeah, so again, there are limited data on the use of IV iron in the first trimester. So it's risk versus benefit that has to be discussed with the mother.
And then do Jehovah's Witness patients tend to refuse anti-D?
Yeah, and so I've had a number of Jehovah's Witness patients who do refuse anti-D. So, it's sort of discussing the risk of alloimmunization with them. Certainly the option to send for cell-free fetal DNA is there. So cell-free serum maternal plasma for cell-free fetal DNA can be sent as well to determine whether or not the fetus is carrying the D antigen. And then again, another discussion about risk if the fetus has the D antigen.
And I think we've covered, there was one last question, besides limiting transfusion, and I guess with RIG, any other ways to prevent alloimmunization, like to prevent other alloimmunization besides, RIG-D for de-alloimmunization?
So from paternal exposure to other red cell antigens, there isn't really at this point. But from the perspective of transfusion, again, it's try to avoid transfusion as much as possible. So if a patient is even mildly iron deficient in the first trimester, is really treating as soon as possible to avoid the situation where there's either the mother is symptomatic or the fetus could potentially be compromised where you have to give a transfusion.
Okay, I think we actually covered all the questions. Nadine, thank you so much. It was like a rapid fire question period.